Hello everyone, my name is Chris Surek, moderator of Cosmetic Corner, and I'm coming to you straight from the Dallas Cosmetic Surgery Symposium. I'm joined by Dr. Jeff Kenkel, Chairman of Plastic Surgery at UT Southwestern and Associate Editor of ASJ. Dr. Kenkel has been kind enough to join us today to talk about the newest article in the Cosmetic Corner edition, looking at disparities in procedures in aesthetic surgery for plastic surgery residents. Dr. Kenkel, thanks for coming today.
Absolutely, happy to be here, Chris.
So the article was very well done. We commend the authors for a well-designed study as well as the commentary that accompanied the article. But what was looking at is they looked at 818 residents in their case logs. And they looked at the lowest 10th percentile and the highest 10th percentile and the folds between the two to look at the disparity in experiences in aesthetic surgery and plastic surgery residencies. This is a known issue. As we know, we're always trying to grow aesthetic training and exposure in the curriculum. But Dr. Kenkel, I want to talk to you about a couple specifics regarding that. First of all, I think it's very much program specific. Obviously, although this was a great study, there were some limitations. There was a recall bias because it is based on the residents reporting their case logs in the ACGV database. And it was a global overview without looking at specific portions of certain program curriculum. Your program is very well known for aesthetic surgery education, so can you tell us a little about your approach?
Sure. Well, first, Chris, I think we need to give credit to the RC and the American Board of Plastic Surgery, who a couple of years ago increased the requirements. So for almost 20 years, we had 50 case requirements for aesthetic surgery, and it was really just focused on 5 surgical procedures. And now, as you know, we've broadened that. We have to have 3 times as many cases now to graduate, and we've included everything from treatment of massive weight loss patients to injectables. Our program has a rich tradition in aesthetic surgery, and for good reason. The majority of plastic surgeons perform aesthetic surgical procedures. I think the last review or statistics I saw was 50% of plastic surgeons actively pursue aesthetic surgery, and up to 80 to 85% at least perform some type of aesthetic surgical procedure. So it is our job as programs to really train them in this important area of plastic surgery. Our approach has been kind of multifaceted. We have obviously strong clinical volume, which obviously is very important. Number 2, we focus on our curriculum and the didactic portion as well. We're lucky we have a lot of really good leaders in aesthetic surgery here in Dallas, so we can ask them. Some of them are within our institution, and a lot of them are in the community, but all very supportive of the educational process. And then the third component is really our resident cosmetic clinic. And that's something that's been around for a long time as well. And that really allows residents to see their own patients, to kind of come up with a treatment plan with their faculty, and then actually do those procedures with those faculty. And that's just experience that's just hard to reproduce anywhere else.
Yeah. It was interesting. In the study, they found that there were 10% of the residents didn't even meet their minimums for dermal fillers and neuromodulators. And given the growing competition from non-plastic surgeons, and obviously the very common request of our patients to have filler and Botox, how important is it that we get this training in residency to prepare us going out into practice?
Well, it's just vital. I'm a big proponent of non-surgical devices and injectables, and it's really, we're going to compete in this very competitive market. We need to have that experience, and so we rely heavily on industry being willing to help support our educational venues, and I think the industry across the board has been very supportive, helping us get product in our residents' hands so that they can learn how to use these different injectables that are out there. So within the resident cosmetic clinic, they can certainly treat patients with faculty supervision. The other thing that's been really helpful for us is quarterly we have a kind of a resident injection session where 3 of our faculty will go up there. We bring 20 to 25 patients in, and then our residents will see those patients for a room with the faculty and then inject them. And the great thing about these little sessions is not only do our more senior residents participate, but we have our first-year residents, our second-year residents, third-year residents that are actually learning how to inject botulinum toxin in fillers. So by the time they graduate, they'll have 6 years of experience, which is really just will allow them to be very prepared to get into practice.
Absolutely, absolutely. And they mentioned the commentary at WashU, they have their resident clinic, and actually at KU we do our own injection clinics with each level resident as well to try and grow that. So I think that's really helpful. The third thing that I wanted to talk to you about briefly was, they mentioned that duty hours has been a concern, that the residents, they quote a stat saying that the residents only spend about 14% of their duty hour time actually operating, And then they said that some people feel that we lose almost a full year of training necessarily because of our duty hour restrictions. How do we mitigate these concerns and limitations, and also how does the milestone process help us to assess procedural competency?
I think all really good questions, Chris. The duty hours thing in surgery has been a point of discussion for many years, and in fact, there are pilot programs now looking at duty hours, and there's even, I believe, 15 or 20 programs in surgery that are actually not as part of an ACGME project that are actually looking at expanding the duty hours in surgery. I think the reality for us is very rarely do we have a resident that falls victim to being at fault for having more than 80 hours. I personally don't think that our residents just spend 14 hours or 14% of their time in surgery. It's a large portion of the time that they're with us. In fact, that's why we created clinic rotations, because a lot of time the residents were just seeing in clinic at our county hospital and our VA, but they weren't really seeing patients pre and post-op, and that was really critical for us. The topic of evaluation is really important. I think the milestones were a really good step forward. The challenge with the milestones is it's a finite number of milestones that we look at, and plastic surgery is such an expansive field. So A, are we going to encompass all the procedures that we do? And then B, one of the key things about learning plastic surgery is you have to learn to adapt. Because we know in 5 years, 80% of the procedures that we do are going to be somewhat obsolete. So you have to be able to interpret articles, watch videos, and then bring that into your practice. So that may be some intangibles that we may not cover with the milestones. I think it's a great step forward. Again, I know there's some pilot programs within the ACGME that are going to actually solely evaluate residents on the milestones, which means a resident may finish a little bit earlier or they may finish a little bit later based on what their milestone evaluations are. There's probably a hybrid in there that we'll work with, but I think it's focused us a little bit. What's important to be a 3 out of 5 in a milestone? I mean, can you actively perform the procedure with assistance?
Right.
What's going to be required for you to take that next step and perform it independently, and ultimately be able to take somebody else through it? So it's allowed us to think about things a little bit more critically, and I think it's been a positive step. It's actually expanded the evaluation process.
Yeah.
I know when we first brought the milestones into our program, it created a lot more work for the faculty because there's a lot more evaluation that they had to do, and we had a backlash from our faculty, so we had to kind of trim it back a little bit. But I think it's a positive thing. I'm not sure where we're going to wind up with it, but I think it's a positive thing.
Excellent. Well, thank you so much for joining
You
us.
bet.
Very interesting discussion, and we hope everyone gets to join us at the 50 Years of Aesthetic meeting coming up. And until next time from Cosmetic Corner, we'll talk to you then.